Good morning. My name is Deborah Goodsell, and I'm the Director for the Clinton Council on Aging, and I'd like to thank you all for coming here today. We've had a lot of different viewpoints on ballot question 1 for this election, so we decided to have some representatives from both sides come here today and explain to us exactly what this bill means and what it means to each one of us. When we talk about this bill, basically the long and the short of it is, a yes vote would limit the number of patients that could be assigned to one registered nurse in hospitals and certain other healthcare agencies, facilities. And a no vote would make no changes to the current laws relative to patient-to-nurse limits. So that's what we're going to discuss today, and we do have our special guests here. From the Massachusetts Nursing Association, we have Dominique Muldoon and Kathy Logan, and from Health Alliance Clinton Hospital, we have Judy Thorpe. So I'd like to welcome you all here today.
Thank you.
Thank you.
Thank you.
So we're going to have, we're going to have each side give a little bit of informational on what their views are on this ballot question, and then we'll open it up to questions afterwards. So we did do a little thing beforehand, and Mrs. Thorpe here will start.
Thank you so much. My name is Judy Thorpe. I have the honor of being the Chief Nursing Officer for Health Alliance Clinton Hospital. I have about 40 years of nursing experience. Some of my most telling experiences as a nurse have been accompanying an 8-year-old to the cardiac cath lab who said he wasn't scared, then gripped my hand until he went into the cath lab, working with a resident to go and talk with a family that we knew were going to break their hearts because their 2.5-year-old boy did not survive cardiac surgery. Recently, working with one of our Clinton campus ED staff as we resuscitated a patient on the grounds outside the emergency department, and worked with him for a long time, and actually had the honor of bringing him back to the hospital a couple weeks later as he thanked us for saving his life. Staffing is at the root of everything we do. Everything. It's a very fluid decision, and staffing decisions change throughout the day. And one of the things that I would want to impress on people as we talk about this very important topic, and a complicated topic, is that one of the most important things that I want to make sure happens is that we are able to maintain staffing decisions in the moment when patient care changes in the moment. The bill is actually 5 or 6 pages long, and actually to read the entire bill realizes how complex the bill is. And some of the unintended consequences of the bill, I think, are enormous and could impact healthcare in the Commonwealth for years to come. I want to highlight 3 of those initiatives and 3 of those consequences that I think are very important for people who are voting to understand. So the first is the topic that says, or the aspect of the bill that says at all times. So at all times is all times. The only exception to the staffing ratios is with a public health emergency. So I think it's important for everybody to understand that. Public health emergency is, the last time there was a public health emergency, there were 2 recently in the Commonwealth. One was a 1-day kind of notification by the governor about the opioid crisis, and the other one was the H1N1 flu. So there's a difference between an emergency such as the Columbia gas explosion or the Boston Marathon and a public health emergency. Neither one of those met a public health emergency standard. So that's something that concerns me. The other thing that concerns me is the fines of up to $25,000 per episode of not meeting those ratios. So that concerns me as well as the ability to obtain nurses and to hire them into positions that we would need to hire into. I give a great example on the Leominster campus. Anybody been to the Leominster Hospital? Okay. So there is a unit at that hospital, it's the med-surg unit. Anybody? Okay, there we go. It's a 30-bed unit. Currently, right now, we have 7 nurses who take care of those patients. We also have contract language that we also need to follow, which allows the staff to have, in addition to the nurses taking care of the patients, we have a charge nurse assigned we call it without an assignment, so they're actually very busy, though they don't have an assigned patient assignment. And our patient, so right now on that unit, we have 6 nurses taking care of patient assignments on a 30-bed unit and a charge nurse. So for that bill as we would move forward, once the new contract goes into effect, those 6 nurses would be able to take care of 24 patients with a 4-to-1 ratio. So the other 6 beds, we would need to hire patients into. So we would need to hire nurses on days, evenings, and nights to get to 28 patients. So that's 7 shifts a week on days, 7 shifts a week on evenings, and 7 shifts a week on nights. So that translates to approximately $450,000 worth of additional nurses on that unit to get to 28. So to get to 29 and 30, I would actually then have to hire another nurse days, evenings, and nights. Even though they would only take care of 2 patients, even if we would only take care of 2 patients, we would have to hire those additional nurses. So when we look at the proposed financial impact of the bill, there are a lot of numbers being talked about, big numbers being talked about. But I thought I'd give you an example that is an example of real time of what would happen at the Leominster Hospital campus for Health Alliance Clinton Hospital. I think it's important for all of us, for you to realize that, that those additional nurses would be needed. And then I think the last thing that I want to touch on is healthcare finance. Healthcare financial status is very, very complicated. Has anybody had like a chest x-ray or a CT scan or an MRI? Okay, and have you ever tried to figure out, I wonder how much that CT scan costs? It's very complicated. How much would it cost you? It depends on your insurance, it depends on your deductible, it depends on all of these things. It's like, can't you just tell me how much it costs? Healthcare is very complicated. We're very highly regulated, and we have a challenging time meeting our current budget. So Health Alliance Clinton is ending the fiscal year, and our fiscal year ended the last day of September, up anywhere between $15 and $15.5 million behind budget, in the red, and the wrong direction. However else you would describe it. So we are financially challenged. Many of you know we have closed services. We've made difficult decisions. We have laid off people. We have tried to close that budget gap now, and it's a challenge. We haven't closed it yet. We still have some financial questions that we have to think about in the very near future, and that's without any additional costs related to the ballot bill. So I think as I urge people and encourage people to think very strongly and educate people about the implications of the bill, is to realize that some of it could be unintended that we don't even realize yet. And though that's an important state. I believe that we will need to close some beds. I believe that it'll be hard to have a unit that's not divisible by 4, because we have a 30-bed unit. To staff beds 29 and 30 could cost us almost $500,000 a year. And I don't know where that money's coming from. I think that one of the things is to listen carefully when we talk about that we have a lot of money, and that healthcare executives and hospitals have a lot of money. I can tell you we don't. Health Alliance Clinton does not. I can tell you that the reduction in force has impacted a lot of people already, and we are struggling to make our budget and what the financial picture looks like going forward. Personally, from my own personal view, to let you know that in 2 weeks, my job has been eliminated at Health Alliance Clinton. So I am one of the people who will have and has had been negatively impacted by our finances. So I can say from the heart, it's not easy. Difficult decisions have been made, and I'm concerned about our ability as a hospital to maintain the service level as we currently wish to moving forward. I'd like to end by saying I'm proud to be a nurse. I'm proud of all the staff I've been able to touch, all the leaders I've been able to touch over the years, and I'm proud of all the patients whose care I've been able to impact. I appreciate you listening to what I had to say, and I know we're going to be actually giving a presentation from people who might have a different opinion than I do. There's no might about it. Do have a different opinion than I do. And then at the end of that presentation, I'll be happy to answer any questions. I thank you.
Thank you. Thank you. I'd like to now introduce to you the Mass Nurses Association, and we have Dominique and Kathy.
My family tells me don't ever put a mic in front of her because she starts singing, so I promise you I won't start singing. My name is Kathy Logan, and I thought I was a nurse for 35 years until Mary Maringo reminded me last night that we graduated in 1978, so I've been a nurse for 40 years now. And I've worked for 35 years at UMass Memorial University campus. So I'm going to give the mic over to Dominique right now, and thank you for letting us do this presentation.
Thank you. My name is Dominique. I'm a nurse. I'm your nurse. I say that because I'm a nurse who's working in the hospital at the bedside every day. I'm not in an office making decisions based on just dollars, cents, and numbers, and not patient needs or patient safety. I'm a nurse making critical decisions at the bedside. I've been a nurse for 14 years, and I love it. I will say that I'm very frustrated that I feel many times I'm undermined by the decisions that executives make as far as my nursing practice, and they're not at the bedside, but that's how I have to practice right now. So I can say that when I got out of nursing school 14 years ago, I realized very soon that things are not, the way they should be on the floor. I'm not able to give the care that I know that I should be giving. There's a certain standard that we nurses ascribe to, and that was not being met. So I got involved with the Safe Staffing Campaign. The Safe Staffing Campaign is not anything new. This has been going on for 20 years. We've been telling our administrators, we've been telling our supervisors that we just cannot do this. We cannot care for this many patients at once and not have any complications or problems. We cannot take care of the patients the way they should be. And we're told to do the best, just do the best that you can do. So when I was in nursing school 14 years ago, it was a very exciting time. All of us You know, we were having labs in classrooms, and we were learning how to, you know, do IV pumps and all this technical stuff, calculating doses, changing dressings, and, you know, we were just abuzz about it. And before we were scheduled to see our first patient and do a care plan and everything, our instructor stopped us all short, and she gave us a lecture. She said, you know, I know you guys are so excited about giving these IV meds and the doses and everything, and understand that these are all part of your practice, and as exciting as they are, you are going to learn them and you're going to know them like the back of your hand. What I want you to remember, never ever forget this, is that when you go see that first patient in that bed, think about your mother, your father, your brother, or your sister. Think about how you'd want them to be taken care of. And don't ever forget it. That's what's going to make a good nurse into a great nurse, because that's the crux of nursing. And I never have forgotten it. You know, at any time when you're in the hospital, you're really sick. You're not there because, you know, it's a hotel stay and you want a glass of water or whatever. You're there because you're really sick. They don't let you in if you're not really sick. And today, nurses are caring for very often twice as many numbers of patients than they should be. For every patient over 4 a nurse cares for, there's a 7% chance that there's going to be a complication. There's a chance that they could die, have an infection, because the nurse is not getting there on time. When you put your call light on, you deserve to have me come into your room in a few minutes. When your antibiotic is due, you deserve to have me there giving it. That's a specific time. That's what's going to help you get better. And you deserve to have me in there to do my assessments the way I should be doing them. I don't know if people realize it, but, you know, nurses come in the room and they look at you and, you know, we're doing a whole thing of assessments. We may come in the morning, listen to your lungs, check your belly and everything, ask you some questions, and very often they're very personal and embarrassing questions, because we're going through all your body systems, because if there's just a little something off, the way you're breathing or the way your lungs sound, or even the way you're talking to us, the way that you're mentating, you know, that can be a sign that something's going on. When we can't get into your room every hour, that something could turn into something worse. Now, your doctor will come in, usually in the hospital, and spend about 5 minutes with you, and then leave. But in the hospital, the nurses are responsible for you all the time, 24 hours a day. And we're very often the eyes and ears. We're the ones telling the doc, you know, there's a little something different here, you know, this patient isn't on their Lasix or they're not on this medicine, and those things should be addressed right away. That's where I'm coming from. And I understand that there's a certain amount of fear about money and how much this is going to cost, but think about it this way. When you're in the hospital and you suffer a complication, or you go home too early and you're readmitted to the hospital because, you know, maybe you didn't know how to take care of your surgical wound, or you didn't take your medicine right, for whatever reason, those things happen all the time. In Massachusetts, we have one of the highest readmission rates. The thing that affects patients the most is now you've got to take more time off from work. You've got to sit in the ER and get admitted to the hospital. It's a terrible, life-disrupting event for you. But it's also a disrupting event for the hospital because they don't get paid. You know, very often the reimbursement's not there. And I believe that if we did a better job, we had better staffing, that, you know, that's going to offset a lot of the cost. A lot of the cost. I also believe in my heart, you know, I'm very passionate that as a nurse, I've learned about ethics. In 14 years, I've had to be around when patients had to make decisions that were very hard, and we've had to use ethics in those decisions. And I believe that hospital administrators should also have to use business ethics. Instead of just saying, this is going to cost you so much, we're going to close your hospital, we can't figure out a way, we're going to jack up your rates, and this is going to be, the whole sky is going to fall in on you if we provide you with safe care. They are just as responsible for providing you with safe care when you're in the hospital as we are. And not providing you with nurses, to do that is a little bit unethical, because we can reallocate, our money to try and figure this thing out. We've had 20 years of it, raising the alarm and asking, come on, let's sit down, let's figure this out. We've gone to senators, representatives, and saying, this is unsafe, we need help, we need to do this. And telling us doing, just the best that you can is not an answer. There's been no back and forth about how we can do this. And you've heard them say, staffing is important, because it really is. We're not just making this up, we've got 20 years of documentation. So with that, I also want to say that, think about it this way. Here's another way of thinking about it is, think about yourself in the bed. You're one of 8 patients, or one of 6. Now think about when you go to the grocery store and you're at the deli, and there's 6 people, you pull that ticket, there's 6 people in front of you. And the lady in the front there, she's ordering provolone, ham, macaroni salad, and she's taking forever. You can take that ticket, you can throw it in the bucket and walk away. Or you can go walk around and do some shopping. When you're in the hospital and you have 6 people ahead of you, you can't do that. Nor should you, because if you have your call light on, it's for a good reason, and you need somebody to be coming and saying, what's wrong, let me look at you and see what's going on. We're not a deli at the hospital. So I want to say that, and I also want to say that I know that there's a lot of talk about closing hospitals and about how to afford them. From what I understand, Clinton Hospital is already at the guidelines. They wouldn't have to hire nurses because they've already been closing services, and they have the same complement of nurses. So, if they're already doing it and they don't have safe staffing and hiring extra nurses, what's the reason for doing it now? That's a real soul-searching question that we should be asking ourselves. And also, I would say that a few years ago, we implemented a law in our ICUs that limit the number of patients, and we're just looking to expand that law. This is not new. This is, working in our ICUs. Patients are safer. And remember, those patients that were in the ICU 10 years ago, they're on our floors now. I'm giving medications and doing things that I never did in the beginning because we're given that much more responsibility and because you need it. You need it. We're doing surgery. I work on a surgical floor on patients that are 80 and 90 years old, and we're getting them through it. We want to make sure that we're getting them through it and getting them home if that's where they want to go. So I would ask you to vote yes on 1, and here is Kathy.
Well, like I said, my name is Kathy Logan. I've been a nurse for 40 years. I actually retired from UMass Medical Center University campus after they laid me off and they closed my department. So I also am a product of one of the financial problems that happened to a hospital, but 1 year after I was laid off, they rehired a whole new department again because they found out that it wasn't cost effective to not have somebody in my role. Through my years and through my experience, I've always been a bedside nurse. I've never been in management. And as a bedside nurse, I have witnessed over the past several years how sick patients have come from the time that I started to work at UMass until they are right now. So as Dominique had noted, that patients that are in an ICU right now are the sickest of sick patients you can possibly have. Patients that we have on the floor are patients 10 years ago that would have been into an ICU. So when we talk about limits, we're talking about limits that are going to give safe staffing for every patient that comes in here or into a hospital. I myself, since I have retired, have had to deal with family crisis and family illness. So this law isn't just for me as a nurse now. This law is for me, a citizen and a patient. And when we brought this law forward, we tried this 20 years ago. We brought it through the legislation, we brought it through the DPH, and we never able to get it through the House. So many people are saying this law is a government-controlled law. This law is not a government-controlled law. This law is a ballot question that was made by nurses in order to look at patients and have patients get safe patient care. It was brought on to a ballot for you citizens, the citizens of Massachusetts, to vote on how you feel so you should be treated in a hospital. And as Dominique had noted, that for every patient that a nurse has over 4, there's a 7% chance of complications, and those complications are medication errors, hospital infections, and acquired other morbidity, and then mortality. And we also, in Massachusetts, even though our opponents say that we're one of the best hospitals around, well, we are, but you've got to find out why. Why are we one of the best hospitals around on the LEAP score pay-as-you-play surveys? Well, one is because the hospitals in Boston already have a lot of great staffing. Mass General staffs on a 3-to-1 ratio, and they're listed, I think, in number 5 in the country. And so all the hospitals that were brought into that survey that did not meet that high standards were hospitals that were around that had unsafe staffing. So what we're trying to say to you is, let's up that bar. Let's have safe staffing throughout Massachusetts, just not in greater Boston area. So I'm asking you that to vote yes, because you're a patient. You're just not a citizen, you're a patient. And when you come in, you need to have care, your family needs to have care, and your children need to have good care. And we in Massachusetts have one of the highest readmission rates in the country. I think we're number 50. That means that when a patient goes home and they do not recover from when they first came in, they're readmitted. And when they're readmitted after 30 days, the hospital doesn't receive any money. Medicare and Medicaid does not pay for those readmissions. We are one of the highest readmissions, and we want to improve that. And we've already got studies, and although the opponents say there's no studies, we have 8 studies that show when you have better safe care, the readmission rate lowers, because the readmission rate lowers because you don't have to keep coming back. And that is one of the cost savings that the hospital will see. When you start getting money put back into the hospital because you have good patient care, that's going to be a win-win for everybody. So please, vote yes on 1.
Thank you so much.
I always get dry when I talk.
So now that we've heard from both sides, I'd like to see if there's anybody in the audience not associated with the 2 groups who would like to ask any questions. Hold on 1 second. Would you like to come up? Would you like me to say your question? I'll tell you your question. Well, it's hard with the thing. So what is your question?
I'm just wondering, she's saying the readmission
Yep.
rates are so high. Are the readmissions, she's saying Boston hospitals are staffed better?
Yeah. So
Better
there's
results?
Yeah.
Are their readmissions lower than the rest of the state?
The Boston ones?
Yeah.
Yes, they are.
So the question is about readmissions. And we're saying how we heard from one of the sides here that the readmission rate is lower in Boston area than it is in other parts of the state. We were just wondering how are the readmission rates in the other parts of the state?
The hospitals that have what we consider unsafe staffing, that means a nurse comes in and she has 5, 6, 7 patients. Those hospitals are the one that score lowest on the metric scores. The hospitals that have good staffing are the ones that score higher. So when you come into a hospital and you don't have the appropriate staffing to take care of you, and you fall, you break a hip, you have a urinary tract infection, you go home, you still have a urinary tract infection, you have pneumonia because your nurse missed something. Your nurse missed something because she can't be there to look at all these patients. Look at it this way. This side of the group here comes into a hospital and your nurse has 4. This side of the group comes into a hospital and your nurse has 6, 7, or 8. Tell me, which side of the group do you want to be on?
All right, and can we hear from Judy?
Absolutely, thank you. So readmissions is more complex because actually we're judged on readmissions for all cause. So if you come in with congestive heart failure and you're discharged home with a safe discharge plan and unfortunately you fall and you trip over black ice and you break your ankle, that's readmission, and we're actually judged against that because it's an all-cause readmission. So readmission rates itself is a complex, not very easily understood metric. I do want to address something that I think is really important for people in the audience to realize, and I can speak, as you know, for Health Alliance Clinton. We have contractually related obligated ratios of 5 patients to each nurse in our hospital on the Leominster campus. In addition to that, we have a nurse who doesn't have patients who's on the unit. And then in addition to that, we also have a nurse who's available to the 3 med-surg units as an additional resource nurse who also doesn't have a particular patient assignment. So I just want to make sure we stress that we have 1 to 5 and we track very closely our compliance with those staffing guidelines.
Does that answer your question?
Does it ever happen that the 1 to 5 ratio isn't adhered to?
So I can.
So this is another question is the 1 to 5 ratio that we just spoke of, if that is ever not adhered to. So Judy, I'll let you answer that one. And
Yep. So we do track our compliance with staffing ratios on the Leominster campus. And so we have a 1 to 5 ratio plus a charge nurse without an assignment. And we actually keep track of when the charge nurse has to take an assignment because that is our fail-safe mechanism to make sure that no one has more than a 5 patient ratio. So our compliance on each of our inpatient units is over 99% compliant with that. So I feel very good about that. It shows our attention and our commitment to staffing. It is a challenge at times in our emergency department, and I know one of the factors of the bill is our concern about the wait in the emergency departments. But we are committed to maintaining that. Also, to address the issue on the Clinton campus, we're actually not at the regulated, proposed regulated staffing ratios on our geriatric med psych unit. So I wanted to clarify that. Thank you.
the rebuttal.
We both do it. You can do. Since I worked at UMass for 40 years, I was also the chair of their bargaining unit for many, many years, and we had just put into our contract negotiations in 2013 patient ratios, of which we agreed to do a 4 to 5. In order to do a 4 to 5, we did that in lieu of having a 1% raise. So the nurses at UMass actually gave up any type of money to have a 4 to 5 ratio. Does it work all the time? Is it adhered to all the time? Absolutely not. We've got grievance after grievance because the hospital does not maintain that 4 to 5 ratio. And what happens to that? It goes to a grievance process, and the grievance process goes up the ladder, and nothing happens. There is no incentive for the hospital to keep that ratio. This is why we actually had put into law an incentive for the fines, so that it would actually put feet to the fire. And about the emergency rooms, California put this law in 14 years ago, and they have one of the best ER waiting times. And guess what? Massachusetts, we're at the bottom. We're at the bottom. We're number 48 in ER waiting times. The one that's ahead of us is Puerto Rico. So right now, here in Massachusetts, you've already got a long, long wait in your emergency rooms.
I also work in a union hospital with ratios, and I would question the 99% number as well, because what happens at our hospital, it's not adhered to, and it was, as Kathy has said, there was a lot of fighting about this to get this. But The issue is that, yes, sometimes it's, what they do is they say, well, you're not going to have a resource today, and that's not really counted in the numbers. So the nurses are taking more patients, and there isn't that extra nurse who helps out on the floor. And our hospital, our resource nurse can take up to 2 patients. Her or his job is to go around, because a 5-to-1 ratio really is not optimal. So that nurse kind of goes around the whole floor and makes sure that the patients are getting what they need. She's kind of like the MASH nurse, is how I like to refer, because, you know, if there's a patient who's waiting for pain medicine, or there's an antibiotic that has to be given and that nurse is tied up, our resource nurse can go do that. She's a bedside nurse. And as I said, the ratios are not, or the limits are not adhered to. As soon as there's a call out, or, you know, they haven't planned for, you know, extra staffing in the ED, they call it a code red, and they say, you know what, all bets are off. You're taking any patient that comes, and we're not even gonna give you any kind of time limit. Usually there's a 30-minute time limit. We can take a patient, take care of them, and then get the next one, but they just will send them right up. And, you know, we understand that there are times when this needs to happen because there is an emergency, a true emergency. The problem is we have these emergencies every week about, particularly in the winter. As for finding nurses, we have a good, strong per diem nurse pool that is canceled on a regular basis at my hospital. Those are like an as-needed nurse. They sign up, and then the hospital has the right or the flexibility to cancel them with no recrimination. So they can call them up in the morning and say, you know, we have a low census, you're not needed. And then, of course, what happens is a couple hours later, the ER is full and they have no nurse, and they just say, do the best you can. We also have flex nurses at our hospital, so that they could flex us up or flex us down according to the census. So they can provide for these nurses, and they certainly could do it with our contract, but it's just not utilized.
And I'm going to grab another question from Carol. You got a question?
So my question is if Leominster Hospital is in this much debt, and I think most of the people who are not obviously part of the M&A, our concern is Clinton Hospital. And so all this that you're talking about is about Leominster Hospital. And if Leominster Hospital is in this much debt and took over Clinton Hospital, and what we care about is our community hospital, nothing in this meeting has said anything that protects, that makes us feel like our hospital is safe, or that our hospital is going to go forward. Mm-hmm. So I guess my concern is all this about money, but it's not going to make a difference if we're not going to have a hospital here in Clinton to go to. So I've heard from the CEO of Leominster Hospital that if this passes, Clinton Hospital could or could not close, and it's wishy-washy. If this doesn't pass, is Clinton Hospital going to stay open?
So let me address the question. I think the most Clinton campus, and I worked at Clinton Hospital as a standalone before, for 2 years before I took the role as the chief nursing officer combined. And I realized how important the Clinton Hospital and now the Clinton campus is to the Clinton community. You know, local hospitals are very important to, especially small communities like this. I think that should the ballot question go through, it's very high likelihood, high probability, I can't predict the future, but high probability that the Clinton campus could change dramatically and or close. I don't know. And I think that that no one can predict the future accurately, but I do know that it would be at risk should the ballot question go through. And I think Clinton Hospital is not alone in community hospitals and small community hospitals being at risk.
Just a follow-up, just about the question, is you had said that you were clear about the ratios in Leominster Hospital, but the Boston College study said that Leominster Hospital was one of the 9 hospitals that wouldn't have to change their staffing for this law. So is that Boston College study not accurate?
So I'm not sure that the Boston College study took into account that the charge nurse who's not assigned to a patient care assignment would be counted as one of the nurses. We believe that in accordance to the to the language that we would maintain the charge nurse without an assignment because we are obligated to do that and as a resource. So we would need to hire direct care providers.
So, are you all set with that? Okay. So just in follow-up, I'm going to just give you each like 5 minutes just to follow up, tell our viewers exactly, your feelings on how they should vote. So
Can we have that?
Yeah.
Oh, go ahead.
Could I just say something?
Sure.
About, as a patient,
Yeah.
and I've been a staff nurse, I've been a nurse manager, in the last 9 years, I have spent nearly as much time being a patient. And I have had bed sores, I've had hospital-acquired pneumonia, I've had foot drop, and I've had an admission where my nurse kept poking more than one nurse would poke their head in the doorway, stand in the doorway, and say, "I'm sorry, I'm too busy. Your family can help you. Your family can get you out of bed," which my kids are not professional people at that time. And but no, my first time out of bed with a hip replacement, they say, "Oh, your kids can get you out of bed to the bathroom. I don't have time for you. My other patient will be really angry if I don't get her medication on time." That's a direct quote from John. And I went through that whole admission saying something is wrong.
Was it Clinton?
No, absolutely
All
not.
right, I just
No, I go to Clinton ER and I'm begging, please let me stay here, don't send me somewhere else. Because someone is taking care of you there. But this place, then a different nurse gave me morphine. My daughter was sitting with me and she watched me fall asleep and watched me stop breathing. She ran out in the hall, my mother's not breathing. And the nurse came in, put my chin up, opened the airway and said, "Oh, there you go, now she's breathing good. I'll teach you how to do this, and I have other patients, I swear to God, I have other patients I have to take care of. If she stops breathing again, move her chin like this, and if that doesn't work, come and find me." I would need a walk. "Come and find me." I don't go back to that hospital, but it's like, it really, there is a difference. There is such a huge difference of which hospital you go to. I've been an inpatient in 4 different, I've been readmitted twice in the same 30 days. Like, I've had everything you said for complications, I've had them. Like, I've had 9 surgeries in the last 9 years, and I've had complications from most of them. And as far as the ERs are clogged up because people are there, their doctors are sending them there for reasons that have nothing to do. If I go to my doctor and they say, "I'm scheduling you for surgery in the morning," why do I have to go sit in the ER for a couple hours when I've already seen a doctor, I'm already scheduled for surgery? There's nothing. But I mean, they just clogged up with people that don't belong there. But my thing is patients deserve more. And if your hospital can't give them more, then it deserves to be closed. It shouldn't be, why are we accepting a bad job from places? We wouldn't accept it somewhere else. If you went to the deli every day, you would go to a different grocery store.
Well,
It's like we don't have choices all the time.
So I'll let you each have just a minute to.
Okay. There's a lot here. Well, I just want to say in closing that the Hospital Association right now makes $28 billion a year. And they should be able to take that $28 billion a year and take that resources that they have and put it back into patient care. They have a choice. They have a choice of where they put that money. They have a choice of whether or not they want to put it in building a new ER with no nurses in it, or they have a choice of putting it back into you. So what you were saying is absolutely true. Today, there's no limit on the amount of patients that a nurse can have. If the question does not if the question fails, that means everything is going to be status quo. And meaning status quo is that Everybody keeps talking about the unintended consequences of this bill. Well, let me tell you what the intended consequences of this bill if it doesn't pass. The intended consequences of this bill is you, the patient, because the intended consequences mean they're not going to be putting money back into you. And you will be like you, getting more morbidity, more mortality. So we need to have safe patient limits in order to provide safe care for everybody, because you deserve it.
And I'm just going to let Judy finish up, and we'll be all set. So if
Okay.
you could just wrap it up.
I'll wrap it up. Thank you. I would agree that patient care is the most important thing that we do. Access to patient services is the most important thing that hospitals can offer patients such as everyone in this room. Whether you've been a patient, and I'm sorry that your experiences have been so challenging over the past 9 years, whether you've been a patient where a family member has been a patient, or whether you're going to be a patient at some point. Those are the most important things that we do, and staffing is critically important. I don't disagree with that at all. I just think that the best approach to maintaining staffing is staffing at the local level so we can make those decisions in the moment. I know there's been some disagreement about the statistics that I've brought forward, and I probably have some disagreement about the statistics that have been brought forward by my colleagues to the right. But the most important thing is access, and we will need, I am no question about, we will need to make some tough decisions in order to continue to maintain access to the majority of patients the majority of the time. So I thank you for the opportunity to come here. My only wish is for everyone in this room to vote. Thank you.
So I'd like to thank you all for coming here today and listening to both sides of this issue so that you can make an educated decision on your own. And like they said, vote. Thank you.